Good evening and welcome to Doctors on Call. I'm Dr. Sandy Stover, faculty member at the University of Minnesota Medical School, Duluth campus, and I'm your host for the program tonight on an upper GI problems, heartburn, ulcers, and gallstones show. The success of this program is very dependent on our viewers. Please call or email your questions and we'll do our best to address them. The telephone numbers and the email address can be found at the bottom of your screen. Our panelists this evening include Dr. Robert Erickson, a gastrointestinal specialist with Essentia Health, and Dr. Stephen Vopat, a general surgeon with Community Memorial Hospital in Cloquet. Volunteers for the Great Gardening Show are answering our phones tonight, and now on to tonight's program. Well, it's good to see both of you guys, and thank you for coming.
Likewise.
It's been fun we've been doing a little talking ahead of time. It's fun to get to talk to you guys again. I think this is a really interesting subject for the show tonight. There's a lot of questions that come up with the GI system, and I'm wondering if we can put up our graphic and have you guys just walk through kind of the area that we're going to talk about tonight. Dr. Erickson, can you start us off?
Sure, we'll start with the lay of the land, if you would, Dr. Stover. The GI, or gastrointestinal system, consists of organs from the mouth to the rectum, and with two glandular organs in between. We have the tubular esophagus that leads from the mouth to the stomach. It helps transfer the food. The muscular stomach that helps break down the food into smaller particles and deliver it to the small intestine, along with adding acid. The small intestine, which we can't live without, there are 20 feet of small intestine between the stomach and the colon. Helps to absorb our nutrients. Then there's the colon as a storage organ, and also it helps to maintain our hydration by taking fluid from the stool into to our body, maintain hydration. The two glandular organs are the liver, creating bile and help digest our food, and the pancreas with pancreatic enzyme to help break down our food and create and insulin production. And I'll give Dr. Vopat the gallbladder there, which he sees quite a bit, take out.
Well, you hit the high points there. So the gallbladder, basically, I get a common question I get in the office is, well, what does a gallbladder do and how can I get along without mine? And basically what it is a reservoir for the bile that the liver produces, and it mixes in with food after we eat. And the gallbladder basically gives you a little extra bile after eating, so it breaks down the fatty foods that we just ate so we can digest them and absorb them better. If we take the gallbladder out, the liver's still there, the bile ducts that travel from the liver to the intestine are still there, and there still seems to be plenty of bile. So it's an organ that does have a function, but when it is not functioning properly and misbehaving, it's also an organ that we can live happily ever after without.
And when you're talking about the gallbladder not behaving correctly, what kind of symptoms might people notice with a misfunctioning gallbladder?
The classical symptoms that we see are typically fatty food intolerance. It typically manifests by pain after eating. And usually the fatty foods are more likely to cause trouble because they're the ones that stimulate the gallbladder more strongly to empty. And the pain typically exists in the right upper abdomen, right by the rib cage, can be behind the breastbone occasionally, can radiate in between the shoulder blades. But that's the classic gallbladder symptom is you eat a burger and fries, 30 minutes later, you're doubled over with right upper quadrant pain, nausea, vomiting. There's a spectrum of symptoms that people can present with, sometimes even just mild nausea or the pain between the shoulder blades or something. But classic gallbladder attack is the right upper quadrant pain and nausea.
And when you're talking about fatty foods, I mean, I can picture the burger and fries being pretty fatty, but are there other foods that are also bother gallbladders?
If a gallbladder really wants to misbehave, any food can do it. And fat is in places that we wouldn't expect it to. A good share of the processed foods and almost all fast foods that we eat. Salads, salad's fine, put salad dressing on it, they're almost all mayonnaise or oil based, and so a lot of that stuff, it is in places where we don't necessarily expect it. But again, if you have a really misbehaving gallbladder, sometimes many types of food can stimulate it and cause pain.
Is there a problem sometimes with the gallbladder getting bad enough that it could become an emergency?
Yeah, occasionally. Okay. Oftentimes people have intermittent symptoms. A very classic thing I see in the office is by the time they come in and see their family doctor and get their ultrasound and get their gallstones diagnosed and they see me, they think back and, Yeah, I've had several similar episodes, but it got better after half an hour, and then it didn't bother me again for 6 months, so I didn't really give it another thought. So often that's the case. Sometimes the very first attack lands you in the emergency room because the pain is so severe, and it can be up in the chest area, you're not so sure you're not having a heart attack. So you call 911, go in by the ambulance, they check an EKG and heart enzymes and all that's fine, and then they get the ultrasound and find that the gallbladder is very acutely infected. And in those situations, oftentimes the pain doesn't go away until we remove the gallbladder. And they can go on, and in severe cases, they can abscess and rupture just like a bad appendix can. It's not common, but they can. So.
And Dr. Erickson, I know, with gallbladder problems, the liver can sometimes be affected. But what kind of problems can the liver have from a bad gallbladder?
Well, the manifestations, sometimes we just detect it on the labs, elevated liver tests that we call. Sometimes the liver tests are so high that we suspect a potential stone has passed from the gallbladder into the bile duct. In these are cases, then we collaborate with our surgeon and have my colleagues perform a procedure called ERCP, where they can go down and see the stone in the bile duct, open up the end of the bile duct, remove the stone out, and then Dr. Vopat and surgical colleagues can take out the gallbladder. So it's often a team approach related to that.
And we have a question from Donna from Duluth, who is kind of wondering about those gallstones. If you just have small gallstones, does the gallbladder have to be removed, Dr. Vopat?
Size doesn't matter when it comes to gallstones. In fact, sometimes the small ones are more likely to get out into the bile duct and cause blockages downstream. So what really matters is presence or absence of symptoms. Occasionally we find gallstones in people when we're looking for something else. And I occasionally see those people in the office, and I like taking out gallbladders, so I ask them about all kinds of symptoms. But if they're absolutely having no trouble at all, they can eat whatever they want, they never have any pain or anything, I just warn them about the potential symptoms, and it's perfectly fine to observe them. Typically, once people start having those episodes of pain, the natural history is they usually become a little more severe, they usually become a little more frequent, and once they start causing trouble, it's usually a good time to look at the calendar and figure out a good time to have the gallbladder removed.
Well, we have another question too about the liver with gallbladder. So Dr. Erickson, is after the gallbladder itself is removed, can the liver itself have problems not having the gallbladder present?
The liver does fine. It functions fine. The one issue that can occur after a gallbladder is taken out sometimes is diarrhea associated with bile, excessive bile, but that can be treated. I'm sure Dr. Vopat sees that quite a bit with a bile binding type of medication to help them out. But the liver does a pretty good job without the gallbladder.
One of the other things that can hurt in that same area are ulcers in the stomach. And so Dr. Erickson, sometimes we refer to that as heartburn, but can you talk a little bit about how an ulcer is formed in the stomach?
There's two general types, or there's two general causes of ulcers in the stomach. One is from a bacteria called Helicobacter pylori. It resides in the mucus layer of your stomach and creates enzymes and passes it downstream and helps to digest the surface of the mucosa of the small intestine. And then the second one is things that we take in, such as aspirin and ibuprofen. So those are the two major causes of ulcers in the stomach, or the duodenum, which is right after the stomach.
And so, Dr. Vopat, I know you've done some diagnostic kinds of things for ulcers, but can you describe a little bit what it's like to have somebody look for an ulcer in the stomach?
So Dr. Erickson and I both do these procedures called upper GI endoscopies. And basically what it is, it's typically a day surgery procedure. The only preparation in advance is just have an empty stomach before we do the scope, so we have you not eat for a few hours beforehand. We start an IV, hook folks up to all kinds of monitoring equipment so we can watch their heart rate, blood pressure, oxygen levels very, very carefully. And then we give medicine through the IV that sedates them, and then there's, on the graphic on the screen, you can see the endoscope. It's basically a flexible telescope. We can steer it around corners, and there's a monitor in the room that we can see the inner workings of the esophagus, stomach, and duodenum. And once folks are asleep, then we slip the scope down. We can take a look at things. We can get biopsies. We can do tests for the Helicobacter bacteria. In the event of a bleeding ulcer or something, oftentimes we can intervene and cauterize or put a clip on the bleeding vessel or something like that. But from the patient's standpoint, we are pretty generous with the sedating medications, and often they, fall right asleep, and the next thing they know, they're waking up and we're done. And the elective procedures, when we're doing them diagnostically, are generally pretty quick, around 10 minutes or so.
Sure. And there's a good question here that we just got about the esophagus. And so as you're going down and looking, you're looking at the esophagus as well, right? And this, I'll have this question answered by you, Dr. Erickson. What would cause a blockage in the esophagus that would make it difficult for people to swallow?
So the number one cause is usually acid reflux coming from the stomach into the esophagus, and it's almost a pH of 1 or 2. I tell patients it's almost a pH of battery acid, and it can literally damage the mucosa of the esophagus and scar it down, cause ulcerations, and it can cause narrowings and cause problem swallowing. The second warning sign, however, if you have problems swallowing and you're of the age, there's esophagus cancer can cause problem swallowing. So if you have heartburn and you have problem swallowing, you say, oh, it's probably related to my heartburn. Beware, because there's other things that can cause problem swallowing.
I have another question from Duluth about sometimes when after eating and swallowing, people have that little coughing up a bubble of phlegm. Is that something serious, or can you think of what might cause a little burping back up of some contents after swallowing?
Well, often that's acid reflux also. It can be a stricture, a reflux-related stricture where the secretions pile up. Sometimes it's a problem related to swallowing in the throat. So patients who have Parkinson's, who have had strokes or things like that, have difficulty with the coordination of their muscles in the throat. So we often need to differentiate problem swallowing from problems in the throat to problems in the esophagus. And that's the two major areas we think about when someone comes in with problem swallowing.
If hiccups are involved, Elena from Hermantown was wondering if when you first start to eat and you get hiccups, will that be involved in the muscles of the throat as well?
Hiccups is involuntary contraction of your diaphragm, and again, the number one cause usually is related to acid reflux. So often we'll treat acid reflux, see if the hiccups go away.
And what kind of treatment, Dr. Erickson, do you normally start with when you've got someone who's got some reflux or other kinds of stomach problems? The
first thing we'll go with simple things, looking at their diet, watching the spicy, greasy, acidy food. It's important not to eat before you go to bed. I always say gravity is cheap, so if you get a wedged pillow and you're at an angle, you keep the material in your stomach at night. Again, it's very important not to eat 3 to 4 hours before you go to sleep. And then one of the mainstays of treatment is reduce the amount of acid or the amount of the product that irritates the esophagus, the acid. So we'll treat with agents called H2 blockers, but more effective what we call proton pump inhibitors. So things like omeprazole, lansoprazole, pantoprazole. Those are medications that reduce the acid and can really help out people with acid reflux.
There's another question from Kay from Hurley, Wisconsin, who is wondering how serious it might be to have had a CAT scan and be diagnosed with a fatty liver. And I might pose that to you, Dr. Erickson, again.
So fatty liver, we're seeing a marked increase in fatty liver. Is it our diet? Is it the increasing waist size in the United States? Pop drinking and things like that. It's 15% of the time it can turn into a scarred liver. But often what fatty liver is, it's a harbinger of our lifestyle, and it's often associated with hyperlipidemia, hypertension, a stroke risk, sleep apnea. And it's often related to obesity. So we'll often work on patients' weight, and if they lose up to 10 to 15% of their weight, we see a reduction in liver tests and an increase in their lifespan by reducing the amount of cardiovascular risk factors, reduction in diabetes. So it's all part of what we call the metabolic syndrome.
So it sounds like the liver can repair itself if there's some better diet and some attention.
Yeah. Again, the liver is really hardy. It can take a lot of hits, and we can help it out though quite a bit.
Yeah. Dr. Vopat, you had made a comment about the discomfort with a gallbladder being similar to heart issues, and Jane from Duluth had a question about what kind of symptoms are you thinking that might make people worried about a heart that might be gallbladder.
Sure. So sometimes it's difficult to tell. The two diseases can mimic one another. If you're having an acute onset of pain, particularly in the chest or upper abdomen, if it's a pressure type pain, a crushing type pain, if it's associated with sweating, pain radiating into the left arm, shortness of breath, particularly if you have risk factors like a family history of heart disease, smoke, or you're personally a smoker or something, all of those things deserve a call to 911 and a trip to the emergency room. If it turns out that you were just having a bad gallbladder attack, that's fine. You'll be okay with your gallbladder for a little while, but you should get your EKG and stuff first. Now, if it's a mild pain that occurs 30 minutes after eating, and it's not related to exertion, it's not associated with a lot of shortness of breath, more associated with nausea, more located to the right upper abdomen and things, you can probably be a little more reassured that that's likely a gallbladder thing, and if it passes fairly quickly, you can see your doctor in a few days and get an ultrasound. But if in doubt, it never hurts to go to the emergency room. Sometimes it's hard for us to tell the difference without running tests.
Yeah, and I think the ultrasound is another test that I think more people may know about than an endoscopy, but the ultrasound is a fairly common in ERs, but also now I think in more offices too, right, to have that availability. Dr. Erickson, there's a question from Jan from Duluth who had a question about what Barrett's esophagus is and what one could do if one has Barrett's esophagus.
So Barrett's esophagus is generally associated with acid reflux. It's many years of acid reflux, acid coming up, irritating the lower part of the esophagus. The body tries to heal itself and replaces it with intestinal-like tissue called Barrett's esophagus. Barrett's esophagus has a higher incidence of cancer. It's higher than the general population. It's not real high, but it's higher than the general population. So when we find Barrett's esophagus in patients, they'll generally undergo every 3 years surveillance to catch any type of atypical cells early, so we can treat them on the surface with various techniques. If we do find serious cells or cancer, then we can intervene on them, because the esophagus is very, very thin and you want to catch any type of changes early, so that's why we survey them for esophagus cancer.
And so what the symptoms for Barrett's esophagus would be similar to reflux?
They're similar. They're usually acid reflux. Sometimes they have no symptoms because the Barrett's actually doesn't have the sensation that the normal esophageal mucosa does, but it's usually after years of reflux. It's generally higher in obese males. Females, not so much. So generally the recommendations in middle-aged males who have large waist sizes, they'll generally require endoscopy if they've had many years of reflux.
And we're talking about adults for the most part. Have you guys seen kids with any issues related to gallstones or to esophageal or stomach problems? And Dr. Erickson, have you had very many kid patients?
You know, I don't practice pediatric gastroenterology. We do have a specialist in our clinic with that, but certainly kids get GI disorders. There's no doubt about it.
Well, we've been talking a lot about prevention as well for some of these things, and you guys spoke about diet. What other kinds of things like coffee or pop or things that are more acidic, do they bring ulcers on, acidic kinds of fluids? Or
not, it's just not healthy. And they are seeing fatty liver in children, from what I've been reading. It's very important to begin very good dietary habits early in life and avoid those sugars and pops and things, because obesity, long-standing obesity, can be a real burden on your body.
How about tobacco use? We know that can influence a lot of things. Is there an influence with issues related to ulcers with tobacco use?
There is. If you have an ulcer and you smoke, it doesn't heal as well. Of course, tobacco use is not good for many, many organs. It's a higher cancer risk even in the colon, not only the lung but the colon. So any type of tobacco use is not good, and starting young is not a good idea.
And I'm going to throw this one in too for exercise. Have you seen exercise help out in terms of some of what we're talking about tonight?
Exercise is always good. It's again, reduction of the weight, good for your mind. Again, healthy living.
Yeah, it's all good things. My dad had a lot of troubles with reflux disease. He had some problems with where the esophagus goes into the stomach, and some people talk about hiatal hernia in that area. He had something a little bit different, but can you describe kind of what a hiatal hernia might be?
Sure. Hiatal hernia is a portion of the stomach that comes into the chest. The high pressure area works with the diaphragm and then special fibers in the lower esophagus called the sphincter. When that gets displaced north or up, those two areas can't work together, so there's higher propensity for acid coming up. So those people who have hiatal hernias and have reflux generally have worse reflux.
We have a question from Kathy from Carleton too about polycystic liver disease. And is there something that people can take for that, a medication to take for that?
Not that I know of. That is a little bit more of a detailed topic, but there's no specific therapy that I know of.
We also have a very good question about other medications that can affect the liver that are hard on the liver. Are there medications you see that if used too much are hard on the liver?
Well, any medication can affect the liver, and I would like to make a point that supplements, we generally see even some liver failure related to supplements at times. Even though supplements are natural medications, I think patients need to be aware, and consumers need to be aware of what they're buying and what they're taking, because the number one cause of acute liver failure is supplements and medications. You need to be real careful what you take.
I know, Dr. Vopat, you certainly have seen people with the different medications that they've used for reasons that have been prescribed, and sometimes supplements on top. Have you had any combinations that you've noticed have been particularly problematic for gallbladders or for stomachs?
Not particularly with gallbladder. I guess one other thing that comes to mind with liver is acetaminophen or Tylenol, which is a common medication that people take, and as long as you take it in moderation, it's fine. But it can be dangerous if you overdose on it. Virtually any medication, though, one of the things that the liver does is it metabolizes a good share of the medications that we ingest and converts them into the active forms. And so, like Dr. Erickson said, many medications can be toxic to the liver. But back to your question, I can't think of anything specific that I see often in my practice.
We have a question here too from John from Duluth, who's wondering about acid in the stomach that we need. So how much is the right amount of acid, and how does that play a role in killing microbes or other things we might swallow in what we eat?
So we don't specifically measure the amount of acid produced in the stomach. We do know that taking acid suppressive medications theoretically can reduce potential B12 absorption, iron absorption. Certainly acid is important in many absorptive capacities, but we don't really measure the total amount of acid. It's a good question, but in some research settings maybe, but not in the clinical setting.
One thing we haven't talked as much about tonight, and it was on the graphic with the gallbladder, is the pancreas. And I know sometimes, and there was a question about a blocked duct sometimes impacting the pancreas. Dr. Vopat, can you speak to how that might happen?
Sure. I mean, I guess commonly what we see is gallstones. That's a common. When the pancreas is having problems, generally it's inflamed, and we call it pancreatitis. And one of the major jobs of the pancreas is to secrete digestive enzymes, which are good for us if they're in our intestine digesting food. They're bad for us if they're leaking out of the pancreas digesting the tissue adjacent to it. And so occasionally the common causes for that are gallstones. Alcoholism is a common one. Certain drugs can do it. Elevated blood lipids can do it in some cases. And then we see a certain case that the doctors call idiopathic, which means we don't know. We can't figure out why exactly it happened. And it can run the spectrum from relatively mild disease that will settle on its own within a couple of days to very severe disease that requires surgery to go in and remove parts of the pancreas, or an endoscopic procedure to put a stent in the pancreatic duct to enable it to empty and that sort of thing.
And you made a mention of alcohol. Does that impact the stomach as well as the liver? We're talking about
alcohol does cause gastritis or inflammation of the stomach and then back to the pancreas. It can cause pancreatitis. So, you know, I think every week we have patients in the hospital with alcohol-induced pancreatitis, alcohol-induced hepatitis when we're talking about things affecting the liver. So moderation of alcohol is very, very, very important for your GI tract.
So I think what you're saying
abstinence.
Is moderation in all things, moderation in fatty foods, moderation in alcohol. As we're thinking about just kind of overall health on that, is there any other things you might want to add at this point on staying healthy? Good food, good exercise? And watching what medications, and perhaps talking with your physician about the balance of everything you take, supplements as well as medications.
Be good to your body.
Be good to your body. I think that's a good way to phrase it. You know, this has been really fun talking to you guys, and remembering kind of how the whole system works together. It's a complex system, and so I really do appreciate you being here.
My pleasure.
I want to thank you guys, Dr. Robert Erickson and Dr. Stephen Vopat, and our phone volunteers from the Great Gardening Show. Please join Dr. Ryan Harden next week for a program on Lyme disease, rashes, and acne, when his panelists will be Dr. Hilary Reich and Dr. Paul Sanford. Thank you for watching. Good night.